thank you very much for coming once again to Kuypers Kliniek, to our monthly experts talk about topics that are changing every month. Today, we're very pleased to have Jantine here, who's an expert in hand surgery. That she will tell us a little bit about her expertise and all the interesting things that a hand surgeon, a qualified hand surgeon, can actually do. And feel free to ask any questions if you have any things. Don't hesitate to interrupt us. Well, you've heard anything. Because I think that's the nice thing about this little group, that we can actually tell afterwards. It will be a lot of fun to talk, ask questions if there's any. All right?
Mm-hmm. Yeah.
All right. Thanks very much.
Thank you. So thank you for being here. I've made the presentation in such a way that I discuss little blocks of the most common issues in hand surgery, and all the time you can ask. At the end, it doesn't really matter. So my name is Jantine Posthuma de Boer, and I'm a Dutch hand surgeon, presently working in 3 clinics in the Netherlands for 3 weeks per month, and then I'll be here for 1 week per month, and hopefully gradually extend my periods here. Next slide, please. For me, what attracts me to hand surgery is that the hand is a super complex unit, both anatomically but also functionally. So we need our hand in all aspects of daily life: cooking, taking care of ourselves, of our loved ones, communication, work, and we need 2 good hands to work on that. And above all, it's also an aesthetic thing, because usually people use their hands in communication and work. And if there are problems with the hand, it shows. And in our society, usually we don't really like that. Because the hand is such a complex unit, the treatments that exist, they are often, I try to tailor them to my patient's needs and situations. They can be both conservative and surgical. Next slide, please. So these are the topics that I will discuss today, one by one. And I think that they are very common hand and wrist injuries. There are many, many more, of course, they exist, but I will not go into them today because that's too much. Next one, please. The carpal tunnel syndrome is a very, very common complaint of the hand. I think it's the most common operation in hand and wrist surgery. Globally or in the Western countries. When you have a carpal tunnel syndrome, you have a compression of the nerve in the hand palm on this level. And it gives rise to numbness, paresthesias at night. Usually people wake up and they want to shake their hand. It can be painful. You can lose your sensation, strength, and motor capacity. And so the yellow thing, that's a picture of the median nerve in the hand. Next slide, please. So ultimately, when the nerve is compressed underneath the little band, the ligament in the hand, it doesn't get sufficient oxygen, and that's why it gives complaints. The treatment can be from a conservative one to a surgical one, and if there's only a mild carpal tunnel syndrome, then usually we start with a night splint to try to get the wrist in an optimal position to make sure that there's a good blood flow to your nerve, and hopefully your symptoms will go away. I think it's only useful in mild cases or temporary ones. Then, if that's not sufficient, you can try an injection. I don't think it's the solution for everybody, because it's usually a temporary relief that you get. And it can have a bit of side effects. But if you want to test your diagnosis, want to make sure that surgery will help, or if there's anything in your life that prevents you from being able to undergo surgery, then an injection can be a super good option. And ultimately, if that doesn't help, then you can do an operation where you cut the white ligament and you give more space to your nerve, and then it can start to recover. If you do that, then a surgery has success rates of above 90%, so that's super high, I think. It's a short procedure, and they can go back to activities of daily living or work somewhere between 3 and 6 weeks, not months, weeks. And I think it's really worthwhile if you have the patient. So I don't know if there are any questions about this first part of the...
So, to put it
Yeah. 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 Yeah.
What's the difference?
I can do both. I think the golden standard is an open surgery because you can do that under local anesthesia. You only need a knife or very little things. If you do an open procedure, you will have a scar this big. If you do an endoscopic one, you have a scar of 1 centimeter on the wrist, and you go into the hand, into the carpal tunnel with a little, boat-shaped instrument, and then you cut the ligament on the inside. The pros of an endoscopic treatment is that you only have a small scar, and people feel that they recover more quick. However, of course, on the inside, you still cut the ligament and it still has to heal. So if it comes to powerlifting, for example, I would say, well, take it easy nonetheless, but it has its pros. The downside is that you need more material. In that sense, it's more consuming. Yeah.
It's with steroid?
Yeah, it's with the corticosteroid. You can mix it with a local anesthesia. If you do that, then people have numbness of their hand for an hour or so. So you really have to guide them, counsel them. And the rationale is that everything gets a little bit less swollen if you put in the corticosteroid. So I think it's the corticosteroids, they work on the tendon, on the outside of the tendons, and they decrease in size. And then the nerve gets more space. And that usually works somewhere between, say, 10 days to 10 weeks. And then usually the complaints, they recur. Yeah.
What's the reason what can get people carpal tunnel syndrome?
I think it's Mother Nature, because maybe it's just a little bit, there are many structures on a very little space. So I think it's just prone to give problems, maybe evolution-wise. And if you get older, your tendons tend to get a bit thicker. There's hormonal influences that can influence the tendons. Hard labor outside in cold, so here maybe it's not so often, but if people work with repetitive strain and repetitive vibration in the colds, people get that. So there's a
relationship with pregnancy.
Yeah. So well, the hormones, they change the tendons, the tendinium. So
Wait and see.
Yeah, for pregnancy, I would start with night splinting. It's not dangerous to do an injection, but it's maybe you don't want that because women feel like, I'm carrying the kid and I don't want to poison it. Women around menopause, they typically have, there's a peak of carpal tunnels, but also tendon issues. Yeah.
Can you tell the difference between that repetitive strain
and the difference, or why?
Are they interlinked?
No. So if there's a repetitive strain injury from desk work, or where people get pain in the arm, neck, shoulder, everything, that's usually a posture issue. And that doesn't really affect the anatomy of the nerve. But if you have pain on the nerve, then it can actually radiate all the way up. And it may mimic, and sometimes it's difficult to know the difference. Yeah.
And do you recommend physical therapy or using the other procedures?
There is a type of physiotherapy where they apply traction. And I know that a group of people, they find that their symptoms, they lessen, but I don't really understand how it works. So if people ask me, am I allowed to go to the physio and am I allowed to do the traction therapy, then I tell them, of course, give it a try. Yeah.
And working with the neck.
Yeah, the neck and the shoulder. Yeah, for sure. But I don't know how the stretching would work. So I don't really know what the numbers are. But
All right. Because when we flex, that the circulation is better.
Okay.
As you work with the little ligaments of the joints, just comes a reflex through the body. Microcirculation.
Better, more oxygen. Yeah. That might be the rationale. Yeah.
I think that what happens many times is we have repetitive strain injuries. People who work as teachers, secretaries. So we might have a pseudo-carpal tunnel, which means symptoms that mimic a carpal tunnel that are actually not.
No.
So in these cases, many people see improvements with a change of an ergonomic change to the mouse, to the pad where they work, and actually with some physical therapy, creating space from the flexors, sensors, and creating space with traction therapy.
Yeah.
So probably it's very important the correct diagnosis in these cases, because you need to know, is this a pseudocarpal tunnel, so something that is giving the symptoms in the medial nerve, then even into the hand, or is it really a carpal?
Yeah. Well, if you want to do, you can do extra diagnostics, for example, is to make an ultrasound where you can measure the diameter. And if it's too much, then you know that there's no room for the nerve and that it's squished and that you have a real carpal tunnel. Or you can do an EMG and an examine by your brain if you really want to know. For example, an injection with the corticosteroids is an alternative, because if it's not a carpal tunnel syndrome, if it's a pseudo complaint, then it doesn't react on the steroids, because it's
Going to start to diagnose.
Yeah.
And when people will have tendency for swelling, which is of course in pregnancy.
Yeah.
You see more diseases. They are more tend to the pseudocarpal.
Yeah. But then you have to treat a pregnancy you cannot treat. But if you have a rheumatism or something, then then it's very important to get that under control and make sure that the swelling is least as possible. That's
So,
all right. Well, next up is a section about tendonitis. I think tendonitis is super common. It can be at any age, but there is also a relationship between activity. There's a relationship with diabetes, rheumatism, thyroid disorders, tendon disorders. A trigger finger is tendons in our fingers get stuck under a little tunnel in the palm of the hand. And it can be painful in the palm of the hand, but it can also catch and lock where the finger is locked, bent, and people find it really very painful, and they have to reduce the finger or reposition with the other hand. You can imagine that it's painful upon gripping something. It can be very cumbersome in activities of daily living. And if it's a long-standing trigger finger, then usually you see that people are unable to completely extend the finger anymore, or completely flex, or both. And when that happens, that's usually of negative influence on the joints. So long-standing trigger fingers are not something that we like to have. Next slide, please. So I'll first walk you through the different types of tendonitis and then go to the treatment algorithm. The Kuypers tendonitis, the Kuypers disease, that's a tendonitis on the thumb side of the wrist, where they have a painful swelling in this area, pain with movements, certain movements like that, or typically pulling the covers at night. That's something that's really painful for people with the Kuypers tendonitis. And it usually is a cause of overuse or special movements that people make, a difference in movement pattern. Holding a baby, lifting the baby like that, carrying the baby. It's always so. There's a lot to do about babies and pregnancy, so the hormonal influences. It's typically something you see around pregnancy and childbirth, but also sometimes I see grandparents with who have the care of their children, and they start lifting up the kids like that all the time, and then they get it as well. Next slide, please. And then finally, the ECU tendonitis. I used an abbreviation you don't have to remember. It's pain on the little finger, on the pinky side of the wrist. That's something that you see also relatively common. It's less common than the other two, but it's a regular problem. You see that with people who also have an overuse. You can see it with people who play a lot of golf, who play a lot of tennis, who have a degeneration of the tendon, or maybe another part of the wrist on this side, and that can give rise to an inflammation of this tendon. And this tendon is a very, very important stabilizer, because every time when we do something with our hand in this position, this tendon has to keep our hand right in line with our arm. So even though you may think it's just a small tendon, it's a hard worker for our wrist in our daily activities. Next slide, please. So when it comes to tendonitis, when it comes to hand issues, it's almost always the same. You start with non-operative options. And in this case, when you have tendonitis, then hand therapy with anti-inflammatory measures is the first thing that you do. So you can do splinting, bracing, activity modification, or being aware of the movements that you make and try to avoid them. Strengthen the other muscles, strengthen the muscles of your lower arm or of your forearm, so that the wrist is in optimal shape or optimal position. Then, if that doesn't work, the second step is injections usually. Success rates, they vary between trigger finger injections or the Kuypers injections. I'm not super inclined to inject in the ECU because that's a bit more prone for side effects that you don't really want for degeneration. And sometimes when you have an issue here, then there's more going on also with a part of your joint, and then it doesn't make sense to give an injection in that tendon because you have to think a bit more. Even though maybe success rates, they are 70 to 85%, if you have a good result and then the effect of the corticosteroid wears off and you have a renewed complaint, you can give repeat injections. Not 20 of them, but you can give a few repeat injections. If necessary, you can also do release operations. You can do release of trigger fingers, of the thumb, to the Kuypers, and these are also short procedures. They can be done under local anesthesia if you want. And recovery times are also between 3 to 6 weeks. Fingers are relatively simple. The tendons, they are a bit longer to recover from. And if you have an ECU issue with also a combined joint issue, then we are talking about different things, and it's a different plan and a different rehab. So next slide. Yeah, are there any questions?
Could you explain the procedure that you perform when operating trigger fingers?
I give a local anesthesia in the palm of the hand. Unless people have severe anxiety and they want general anesthesia, that's fine. I make a longitudinal incision through the skin. Underneath there's a bit of fat. You work through your way onto the pulley, onto the little band that's there, and that you cut in the longitudinal direction. You make sure that it's entirely free, so you have to make sure that up to where the finger starts is released and a bit further into the palm of the hand. And then I ask people to move their finger, or I move it for them, to make sure that there's no clicking and catching anymore. And then you leave the pulley, you just leave it be, because it will recover in a slightly larger situation. And then I stitch the skin, put on a Band-Aid. I think if I do that now under local anesthesia, it's about 7 minutes, the entire procedure. So it's...
And that's called the exposing the finger. It's, for me, just not responding
to therapy. No, I think it's I recognize that if it's in the beginning, or if something happened, people had a little trauma, then I think it's inclined to go away. No, it's not.
It's right. Different types.
No, and usually when you do that, you find that because of the friction between the pulley and the tendon, the pulley is thicker and it's sturdy, and it won't fit the tendon anymore. And I think if that happens, then whatever you try to do to the tissue from the outside, nah. And trigger finger releases, they have success rates of 98-99%. It's something that I would suggest readily. And I usually leave in the stitches for 7 to 10 days, but I'm really kind of slow, because I feel if you give the hand a good rest in the beginning, then they recover better. And after I take out the stitches, people can start moving their hands as they see fit.
This is true.
if you do a release, then success rates are 98%. So 2% of people, they can. Usually when I see people who don't get well, they are never very well. So they never start moving as we would want. And then you can have adhesion between the tendons or a lot of scar formation. But there is a tendency of a hand to make trigger finger. So if you have had one trigger finger somewhere, it's likely that you may have a second one somewhere in life. Yeah.
If you have spondylolistheal, if it's like a community, does that like it personally carpal place?
No, it shouldn't. I think because it's a different system. It's a different health system. I think if you have a scoliosis and for some reason there is a neurocompression in the neck, yeah, you can have a double compression syndrome, but that's with regard to the carpal tunnel. And
my girlfriend is a graphic designer. She's had pain like
all the time, and she has a scoliosis or no.
But yeah, so I'm telling her to stretch.
No.
Does weight training help?
It usually, well, depends on what for. So I think to have, for example, if she uses her hand and arm all the time, then it's really important to have a good posture and to make sure that the muscles of your arm, yeah, that at least they are trained and they can bear the load that she puts on them. So that's important to have a balance.
Surgeons can help it enough?
Yes, I had one myself. I recovered pretty, yeah. And then it's always the question, who are you going to ask to do your carpal tunnel release? But yeah. So yeah, surgeons do. If there is another syndrome where you have a problem with the median nerve in the forearm, and in those cases, it's typically bad to do a lot of training with, because that gives it more compression on the nerve.
Yeah.
Until where doesn't have surgery.
Well, it depends. I work up to, say, here, the ulnar nerve, or the arcade. So if there's a median nerve compression here, I'm not really a big lover of the elbow joint. I can see people and I can do my diagnosis, but I do not do, not anymore, arthroscopy, for example, of the elbow joints. But there is a doctor who is super good in tennis elbows. So, but yeah, so I do hand, wrist, and nerve compression.
Yeah. Do you do shoulders?
I don't. No, I used to back in the days, but no, not anymore.
And shoulder effect with tendonitis and shoulder plus tendonitis.
You can't. I think it's not the case that the inflammation starts another inflammation, but it will for sure alter your movement pattern. And if you have a different movement pattern in the entire arm, then we call that Gaten link. I don't know. So everything is linked. So for sure it's a chain. So if there's a block in your spine or the upper shoulder muscles, it can be there can be a chain towards other tendons.
To repair this, the cause is coming.
It can be, but when I do, for example, physical examination, it shows it's thick, it's red, it's super painful. There are specialized tests to do to find my diagnosis. All right. Any other questions, or shall I go? Well, this is a bit of I put everything on a heap because osteoarthritis of hand and wrist is pretty broad. Osteoarthritis is a condition in which the cartilage of your joint gets thinner and thinner, and you can get pain of the joints. They can be swollen, they can be warm, they can deform. Sometimes you see elderly people with fingers that go everywhere. The base of thumb, so this joint is the most commonly affected joint in the hand, and that's because the thumb works in a different direction from the rest of our fingers. So it's a pretty large range of motion, and it's is load bearing. So when we pinch something between our fingers, then 12 times the load of the weight between your fingertips is conveyed to this joint. So it's a hard working joint, even though it's really small. Next slide, please. Maybe you agree, but again, we start if we treat with conservative therapy. I think for base of thumb and for finger osteoarthritis, there are many good types of splints, and they give a good pain relief in about 85% of the patients. And ultimately, the goal is to support the joint and to make sure that the inflammation goes away. Because with the inflammation away, there's less pain and there's more function. Also here you can give injections. You can give injections with corticosteroid, but also with cartilage components or hyaluronic acid, or maybe even platelets. And the goal is to calm down your joint. Also a combined treatment of injection and bracing, they can give positive results in 80 to 85% of people. So I think that's a very common procedure to give to your patients. When it comes to operations, there are maybe 100 different things that you can choose or that you can go for. So I won't go into all of them, but at least when you have osteoarthritis of the small finger joints, there's a solution. You can fix them, like make them grow together. Then there's no pain anymore. You can do joint replacement in the PIP joints, the small joints. You can do a resection in the base of the thumb and fill the void with a tendon so that there's no joint pain anymore. Usually these operations, they take a bit longer to recover from. So it starts from 6 weeks, I think, and between 6 and 12 weeks, you'll get, anywhere starting recovery. So I always warn my patients that it's a long way to go if you do that. So you really need to choose the optimal time to do this type of treatments. But if you do them well, I think if the pain of the osteoarthritis is gone, then you really get an improved function. So next slide, please. Yes, please. Describing when I worked in the Netherlands, then I usually send people to a hand therapist, or there is a super manometric. I don't know if you ever heard of it. There's a super good company who makes 3D printed splints. Here I've been looking around and I've been talking to one of my hand therapists in the Netherlands, because there are a lot of prefab splints also that do the job, but sometimes it's a bit of a journey to find the ultimate one. I don't know if you have any. No, it's just nothing. Latest. Yeah. Oh yes. I think I should talk to the people from Manometric to see if they cannot be of help here, or whether they have partners here, because it's. That's what you're saying. Yeah, Manometric. I mean, do you know it? Yes. I just bought a big therapist couch for mine. You in here? Okay. Well, I should talk to them.
Next to Kliniek in our clinic in Marbella.
Yes, I saw.
Which sells to platforms that we can talk about.
I checked out the website and I was thinking of going to the store to sniff around, to look around, because I'm sure that they have plenty. Yeah.
I'm pretty sure they will able to you Muslims that.
Because also, for example, the carpal tunnel. Well, anyway, but I know right next to your clinic there's an orthopedic store, and I think they have plenty of things that can work. But crazy or silly enough, for example, there are splints for the Gravens that I would advise for the Gravens, but I also have patients in the Netherlands who use them for the base of thumb osteoarthritis, because they find them far more convenient and helpful. So it's not. Yeah, sometimes it's just a trial and error to find the best solution. And I will try to find partners here.
I was your advice about wearing the braces 24 hours a day, or is?
Oh, it's super dependent per patient. I think many patients find them a bit uneasy or uncomfortable to wear, and they say, yeah, but I want to play golf, and then I have a splint around my hand. Then I tell them, well, you can also wear them at night, 8 hours, for example, because then you have many hours where you have the support and your joint gets to calm down. And if you're lucky, then you can just live through the day without the splint and put it back on at night. But I also have patients in my say register who say, yeah, but whenever I go into the garden, I put on my splint because otherwise I won't make it. So actually, I think my advice is, the point is to try to reduce the load bearing, so to protect it during activities. But if you really cannot work with that, then try to use it as much as you can at different times. There's no...
You don't get atrophy of your muscles.
Well, part of the hand therapy is strengthening exercises for your muscles. You don't believe it; you think that there are hardly any there, but they are. And they are super simple with an elastic band or with a plastic tube or something. Yeah.
Is the arthritis linked with the tendonitis as well?
No, no. But when you get arthritis, you can get swollen joints, and that can affect your tendons. But on the whole, it's also a separate process.
So if you would do it, you said you could do replacement joints.
Yeah. Silicone ones.
Silicone.
Yeah. So then you, for the fingers, for these joints, for these, they also exist. They are, we don't really know what their longevity is, so we don't know how long they will stay in place if you put them there. But for these joints, you can put in silicone prosthesis, where you take away a little bit of bone, you take away all the painful cartilage, and you put in a spacer. It works.
And what's the recovery time, can you say?
I would ask people to wear a body tape to splint the fingers together for about 6 weeks. And if you operate on fingers like that, then it takes a while before the swelling goes away. So the first 6 weeks to 12 weeks, you have a swollen finger, but the pain, the osteoarthritis pain is gone. So it makes fingers much more workable for people. Yeah. And they should be able to stay in for at least, say, 10 years.
10 years.
Yeah. But it's also dependent on what you do with them. So yeah, I don't know. Yeah, but they can work. Yes.
On this picture here, what are all the rings?
We call them silver splints, and they are designed to give a rest and an optimal position to these joints. But you can also put them on the smallest finger joint. You can put them around the thumb. You can put them around the base of the thumb.
And what does that do?
It gives you support. It supports the joint, and it makes sure that there are less forces in that way or in that way. And when your joint is painful, it doesn't like forces in those directions. So when you protect the joint with the silver splint, then people can get a pain relief by wearing those splints. And what people find very nice about silver is that it doesn't stick to your skin. They are resistant to water or dirt, you can clean them very easily. Some people even find that they are aesthetically, they look better than other types of splints. So if you have an osteoarthritis of these fingers, then you're not willing or not able to undergo surgery, then they can offer,
So sorry, when you have like a figured finger, the surgery we did there means that how it's going.
It depends on where, but if you do, if it's painful and deformed, then, for example, if it's this joint, there is a limit to say 20% deviation you can cut off more or less bone on one side to make it fit. Yeah, that works usually. Yeah. Sometimes, but that's never super nice surgery, but it can also work. You can also have these two grow together and fix that joint, but then you wouldn't have as much. No, pepper. Yeah. So the bone resection, with bone resection you can correct deviations.
Is the space
No more. But I will work on that.
What causes the swelling in percutaneous?
Inflammation. Yeah. If cartilage gets very thin, then the inside lining of your joint get inflamed, and it swells. It turns red. It's what gives the pain. It's an activation of the tissue. So that's why, for example, anti-inflammatory drugs, either pills or injections, they can work because they calm down the inside lining of the joint. And in fact, the fact that there is no cartilage anymore, that's not painful, but it's the inside lining of the joint that's painful. So if you treat that, they are a good way ahead too.
I had a condition which I had to take steroids.
Yeah.
And it really helped.
You felt rejuvenated, yeah.
But when I came off, it started to come back. Look, I went on to like an ibuprofen.
Mm-hmm.
That helped.
Works a bit, yeah. It's a different type of anti-inflammatory drug, but it quiets down your synovium, as we call it. Yeah. All right. Next one, maybe? Yeah. So I think we had the Q&A. Then finally, Dupuytren's disease. Dupuytren's disease is something, it's relatively common, but I don't know if anybody's heard of it.
We were taught in medical school that when you have a Dupuytren contraction, it means there's a liver disease. Is that true?
No, well, there's a lot of things that we don't know about Dupuytren's disease, but I think a systemic disease, such as liver disease, has no influence. But there are genetical influences. When you have Dupuytren's disease, you can form nodules or strands or cords in the palm of the hand, which can ultimately lead to flexion contractures, where the fingers, they grow like that or like that, and they won't go straight anymore. It's different from a trigger finger, because a trigger finger can be locked and you can pull it straight again. This you cannot pull straight again. It's also called the Vikings disease because they think that back in the days there were a lot of people with Dupuytren's disease in northern Norway, and when the Vikings, they were pirates, they started taking land, they spread their genes and they spread this disease throughout the northern parts of Europe, which is why I think down south here it's less common. It's less common in Asia, it's less common in Africa. But in northwestern Europe, it's more common.
It's quite common in the UK.
I think, because that's where the pirates went, I think. That's it. It's typical. And I also put, it runs in the family. So it's typical that if both parents have Dupuytren's disease, it's more likely for the next generation to also have Dupuytren's. And it tends to be more aggressive, so to grow faster. The further it runs in the family. So if you have grandparents and parents with Dupuytren's, it's a negative message for you. And so ultimately, if your fingers are like that and you cannot straighten them anymore, people have problems with putting something in their pocket, reaching in the bag, gripping handrails, self-care. They stick their fingers in their eyes or in their nose when they want to do that. And when that happens, then it may be time to do something. It's benign, so it doesn't kill your hand. It doesn't spread, but it can be very, irritating. Next slide, please. So my advice is, when you have something in the palm of the hand, be it cords or nodules, and it's just there and it doesn't really bother you, then leave it be, because it's a disease, so it progresses, and anything you do, it will make it worse at that stage. But by the time that there is a functional impairment of any sort, we can decide together if we should do something. And there are minimally invasive techniques and there are open techniques. The goal of the treatment is to get your fingers more straight for as long a time as possible, because it recurs always. So the chances of repeat treatment, they are high. The minimally invasive technique, that's done under local anesthesia. I just give an anesthesia in the hand, and I take a little needle and I try to rupture the cord with my needle pins, and then I pull the finger straight, and then that's it. Recovery times for that, they are just 2 days or 3 days. You put on the Band-Aid, you go home, you take the Band-Aid off after 2 days, and you're done. On average, people have a positive effect for about 3 years. So it's also a bit of a quick and dirty procedure, but 3 years is 3 years. You can do a lot of things before I see you again. And then the open surgery, it's where, maybe you can see the scars on the right side. It's where you really make a scar in the hand palm and you take out all the tissue that's there. Recovery times are 3 to 6 weeks, depending on how fast your recovery is and how fast the edema goes away. And usually people stay away from me between 5 and 10 years before it comes back. But that's highly individual. So if everybody in your family has it, then probably you'll be back earlier. So
these nodules, can they come and go?
Yeah, well, officially they shouldn't be able to, but I know people in my patient population who have a nodule and it's a bit painful and it's a bit active. And then I tell them, well, wait. And sometimes, but that's almost never.
And then they go.
And then they go.
But they're not painful.
No, well, that's perfect. So it could very well be Dupuytren, but if you don't have a functional impairment for over those, then you just leave it be. Yeah. Next one. We are up to the final Q&A, I think, if there are any questions for this.
Something you have on one side or both sides?
You can have both. Usually, I think people will develop Dupuytren's in both palms, but the severity can be,
Is the last 2 fingers all?
They can be all, but the last 2 fingers, they are, most often affected. And that's good. When they are these 2, then it's good news. When it's your thumb or your index finger, it usually means a fast progression of your disease. You can also have nodules on the soles of your feet. Your toes will not grow crooked, but you can also have nodules in the soles of your feet. Yeah. So, all right. Well, then
Do you use trauma that fit with the
little. I used to do that when I worked in Belgium, but now in the settings where I work, we do not have an emergency department. So either I do delayed treatment or delayed tendon repairs I can do, or corrective osteotomies or scaphoid non-unions. In my setting, I never get a distal radius fracture, which I can do surgery on today or tomorrow, because there's no we could, but maybe I think we could, but I don't know if this setting is easy for that.
I have some time. It's 2 weeks to build in.
Yeah.
Fracture to wrist.
No hurry. So
it's very often we have inheritance because it's very complex, very common. It's really complex.
Yeah. So,
and I know many people at the end it cannot be us.
No. Well, yeah. So to do wrist plating, I did many. So I can do that, but currently where I work in the Netherlands, I don't. Maybe next year when in Hoorn, I don't know where you know where it is. We are building a new building, and then with a bit of luck we can help out the traumatologist in the hospital.
I do have an extreme strength. I mean, that's the estimate. So to ask, when you get a patient with an amputated finger, that's been unized after the amputation. How does it work to put a finger back that has been
unized? Well, there's a sequence that you have to follow, or it's advised. A finger doesn't have muscles, and that's good because a muscle cannot go without oxygen for a long time, but a finger can go without oxygen for a pretty long time, say 12 hours. You want to start your reimplant be, say, before 6 hours, because otherwise the chances of things healing are small. First, you start with a bony stabilization. So you just take a K-wire, like a thread, and you put the top back on and put a thread in, because at least the bone is there. Then depending on if the structures are still there, because you have to look for the end, right? Because if the artery isn't there anymore, there's nothing to connect. Then you first start with one artery to get the blood back into the fingertip. Then you can decide what to do. Find another artery if you feel that's necessary, but if you feel that you have very little time, then one artery is sufficient. You stitch back the flexor tendon, you stitch back the extensor tendon, you stitch back the nerve, and finally you stitch back a vein, because when the blood goes in, the blood has to go back out again. Usually if re-implantations fail, they fail on the venous, on the return flow.
Why is that?
Because they are so small. Yeah. And they make thrombosis, it starts swelling, the pressure in the tip is too high to make the blood go away. And to be honest, it doesn't really make sense to do a re-implantation on this level. So if it's only the fingertip, there's little gain. But any other level you can do. Yeah. If you don't do the tendons, there won't be any movement, and people will get a stick sticking out. So then you really have to think whether it's worthwhile. So not all fingers are reimplanted. If it's a single digit, sometimes you don't. The thumb is always reimplanted because it's so important. And if you have multiple digits, then you always try to give your patient a few digits so they can grasp. So yeah.
You can do a big toe.
Yeah, you can do. You can do a toe to thumb transfer. Yeah, a second toe to thumb. You can make a thumb out of your index finger.
Another thumb grip.
Yeah, well, maybe the simple ones are more nice to talk about. Yeah.
For 7 minutes.
Yeah. So. Yeah. Any other questions? Or? Yeah. So this is because I spoke about things, but that's just a list of things that I do, that I like and like to treat. So I can do arthroscopy when I look in the joint to see if there's anything wrong and if things should be reattached that are detached, or things that should be cleaned up. I can do that. So I can do the degenerative, the osteoarthritis, the tendons. I can do tendon repair, for example. If you have older lesions of a thumb, which is hanging like that, going nowhere, I can do tendon transfers to make it work. Nerves, carpal tunnel, cubital tunnel. I like the cubital tunnel too. Dupuytren, and then cysts, so bumps on the finger, because they are usually, it doesn't really have a functional deficit, but it can look really awful, and people sometimes just want to get rid of it. No.
The type of there's second
We have often
not well in the trauma.
Yeah, I can do that. Yeah, equally. Yeah, for wrist, for hand. Yeah. All right, that's it. Long talk, time to talk. Well done. Thank you.
All right. Thanks very much for this nice talk. Thank you very much for your attendance. You're welcome to join us for a few more drinks or floaty talks. And if you have any questions,
Yes, ask
somebody else, feel free to ask. And otherwise, we'll see you in 4 weeks together, and always on the last Thursday of the month.